Hi, good morning everyone. So are we live? I think we are live. Can't see myself live. Waiting, guys. I can't see myself live. Is there a lag? Mm. Alright, yes, so we are live. Alright. There was a lag in my mobile. I'm so sorry. So I'm Dr. Sonal Parihar. How was your weekend? Sunday को हमारी छुट्टी थी and we had our last class on Saturday. So that is it. एंड आज हम क्या करने वाले हैं, आज हम वापस से PIH, PET एंड एक्लैम्सिया के जो लेफ्ट ओवर क्वेश्चन है वो करने वाले हैं. हमने सैटरडे मॉर्निंग करा था एंड देन वी आर बैक अगेन विद द न्यू सेट ऑफ क्वेश्चन. सो आई एम डॉक्टर सोनल परिहार, योर OBGY ट्यूटर, कंसल्टेंट गायनेकोलॉजिस्ट इन माय ओन प्राइवेट हॉस्पिटल जोधपुर. एंड मेरे 2 चैनल्स हैं. मैनी पीपल कीप आस्किंग मी मैडम आप कब डालोगे वीडियो. सो इफ़ यू फॉलो द चैनल दैट इज़ डॉक्टर सोनल्स ट्यूटोरियल्स, तो इस पे आपको वीडियोस दिखते रहेंगे. हालांकि मैं बहुत रेगुलर नहीं डालती हूँ, बट देन देर आर मेनी वीडियोस विच आर ऑलरेडी अपलोडेड देयर. एंड आस्क योर गायनेकोलॉजिस्ट इज फॉर द पेशेंट्स. ठीक है. देन अनअकैडमी लाइट इज द सब्सक्रिप्शन जो कि आप लोग अभी ले सकते हो जिन लोगों का एग्जाम अभी आ रहा है. दिस इज जस्ट फॉर अ मंथ सब्सक्रिप्शन एंड दिस इज लाइट बिकॉज इट हैज़ ऑल द 19 सब्जेक्ट्स एंड ओनली MCQs. और अभी मैं आपको बता दूँ 25 तारीख से 28 तारीख तक स्पेशल ऑफर चल रहा है. मैंने टेलीग्राम ग्रुप में भी डाला था. गो एंड अवेल दिस. 25 से 28 में आपको फ्लैट 20% डिस्काउंट मिल रहा है. नॉट 10% बट 20%. नॉर्मली आप जब मेरा कोड यूज़ करते हैं डॉक्टर सोनल, आपको डॉक्टर सोनल कोड यूज़ करने से 10% डिस्काउंट मिलता है, बट अभी इन 4 दिनों में 20% डिस्काउंट मिल रहा है. सो दैट्स अ वेरी गुड अपॉर्चुनिटी. ठीक है. देन MBBS Prof 1 इज फॉर एनाटमी, बायोकेम एंड फिजियोलॉजी. डाउट क्लैरिफिकेशन सीरीज स्टार्ट हो चुकी है, खत्म होने वाली है. 6 अप्रैल से स्टार्ट हो चुकी है. प्लस इज ओनली एन अकेडमी जिसके के अलग अलग सब्सक्रिप्शन अवेलेबल है. 2 मंथ से लेके 4 ईयर्स तक के सब्सक्रिप्शन अवेलेबल है, डिपेंडिंग आपका एग्जाम कब है. राइट. देन आइकॉनिक इज फॉर अनअकैडमी एंड प्रेप लैडर, दोनों का कॉम्बिनेशन विच इज़ अ वेरी गुड ऑप्शन फॉर यू. बिकॉज अगर आपको अनअकैडमी से भी पढ़ना है, प्रेप लैडर से भी पढ़ना है, तो दोनों का कंबाइन ले लो, तो उससे आपको सस्ता भी पड़ेगा एंड मिनिमम सब्सक्रिप्शन इसका 6 मंथ्स है. ठीक है. कॉन्ग्रेचुलेशन टू द लास्ट ईयर टॉपर्स. स्पेशल क्लास हमारी आज शाम को है वापस से 7 बजे. डेली क्लासेस होती हैं 7 से 8:30 के बीच में एंड नेक्स्ट मंथ से हम टाइम चेंज कर देंगे. ठीक है. तो ये फ्री क्लासेस होती हैं. दीज आर फ्री. यू जस्ट हैव टू यूज माई कोड डॉक्टर सोनल टू अनलॉक एंड दीज आर वेरी इंटरेक्टिव क्लासेस. ये बैच बन चुका है 1.5 मंथ का. आप लोगों को ऑल द बेस्ट फॉर द 21 मई एग्जाम. आई डोंट नो आपका एग्जाम पोस्टपोन होगा कि नहीं होगा. मैंने आज ही कल रात में एक वीडियो अपलोड किया है. देर आर लेस चांसेस कि ये पोस्टपोन होगा टिल सितंबर. सो यू बी प्रिपेयर्ड फॉर 21 मई और ये बैच आप ज्वाइन कर सकते हैं जो भी आपका मिस आउट हुआ है. ऑल द 19 ट्यूटर्स आर देयर. तो ये सारा जो भी मिस आउट हुआ है सब आपको मिल जाएगा. देन दिस इज फॉर द FMG बैच जिनका की एग्जाम 4 जून को है. उनके लिए 2 मंथ्स का बैच है. बैच स्नैपशॉट. अब ये जो बैचेस लास्ट वीक ऑफ अप्रैल के लिए बने हैं ये आप देख सकते हैं. 20 अप्रैल से 20 मई तक रिविजन क्लासेस 140 आवर्स है. ऑल एजुकेटर्स इंक्लूडिंग मी. देन ये निमोनिक्स बैच है डॉक्टर निकिता का. देन दे विल बी अ प्लस टेस्ट कैलेंडर. प्लस यानी कि पेड प्लेटफॉर्म है जिसमें कि अलग अलग टेस्ट हैं. OBGY मेरा वाला 29 अप्रैल को 12 बजे है. इसका आप एक स्क्रीनशॉट ले सकते हो. सो दीज आर ऑल द टेस्ट विच यू शुड अवेल इफ यू हैव पेड. प्लस क्लासेस हैं ये. ठीक है. नीट PG प्रीवियस 4 साल के क्वेश्चन पेपर्स प्रीवियस 4 ईयर्स ऐड हो चुके हैं. INICT, FMG एंड नीट PG. गो एंड परचेज इट. इनका हेल्पलाइन नंबर है 85. अवेल दिस. कॉल देम, टेल देम हमको ये यूज़ करना है, हमको ये वाली चाहिए क्या नाम है सब्सक्रिप्शन एंड डॉक्टर सोनल इज़ द कोड टू गेट द डिस्काउंट. 20% अभी 4 दिन के लिए, बाकी रेस्ट में 10%. ठीक है. नीट का AIMT टेस्ट जो कि पिछले महीने भी हुआ था, अभी पिछले महीने 17 अप्रैल को हुआ था, अभी 1 मई को वापस से आ रहा है. सो दिस इज ऑल द सब्जेक्ट्स टुगेदर एंड आपको एक ऑनलाइन आपका रैंक भी प्रेडिक्ट हो जाएगा. इसको वीडियो आंसर्स में आपको आंसर्स मिलेंगे. ठीक है. न्यू ऑफरिंग्स आई नहीं, डेडिकेटेड सेशन से ये सब चालू है और आप इसको हेल्पलाइन नंबर पे कॉल करके पूछो. कमिंग टू द स्लाइड विच वी लेफ्ट, that was question number 16. रिस्क फैक्टर्स फॉर प्री एक्लैम्जिया ये हम कर चुके हैं. रिस्क फैक्टर्स फॉर प्री एक्लैम्जिया अगेन हमको पता है क्या क्या है. क्रॉनिक हाइपरटेंशन है, स्मोकिंग नहीं है, ओबेसिटी है, मल्टीपैरिटी नहीं है, प्लासेंटा प्रीविया नहीं है. ठीक है, तो ये सब हम कर चुके हैं. वी विल कम टू दिस क्वेश्चन नाउ. विच ऑफ द फॉलोइंग इज सीन इन प्री एक्लैम्जिया. ठीक है, विल स्टार्ट फ्रॉम दिस पर्टिकुलर क्वेश्चन. Which of the following is seen in preeclampsia? 14 people are watching. I want all of you to participate and give me the answer. Write the question number 19 and then put the option. Okay, so that becomes easier because YouTube पे थोड़ा lag चलता है, so it will be easy. Okay, Pratibha, so you are answering question number 19 and according to you it is, which of the following is seen in preeclampsia? You are saying it is A. Anyone else? It's a PGI question guys, so more than one options can be selected. If you think more than one सही है तो आप इसको लिख सकते हैं. Okay, somebody is saying A, कोई कह रहा है B, कोई कह रहा है C. प्री एक्लैम्जिया की बात हो रही है बच्चों, डोंट गेट कंफ्यूज्ड. प्री एक्लैम्जिया अगर आप लोगों ने मेरी सैटरडे इवनिंग की क्लास अटेंड करी है तो उसमें कुछ क्राइटेरिया ऐसे हैं जो कि निकाल दिए गए. ठीक है, सम क्राइटेरिया हैव बीन रिमूव्ड. सो A and B, yes Pratibha, it is A and B and that is the right answer. It is hypertension and proteinuria. Convulsions eclampsia में होते हैं. Pedal edema has been removed because pedal edema does not change the management. Moreover, we don't know pedal edema किस वजह से हो रहा है. Even normal patients without any preeclampsia will have pedal edema. It's very very common for patients to come back with pedal edema, especially the obese ones, the ones who are not having any high blood pressure, any preeclampsia. Even उनको 5वें 6ठे महीने से 5th 6th month से preeclampsia हो जा, I mean edema हो जाता है. So let me read out the answer. Hypertension we know as defined as systolic BP more than 140 and diastolic more than 90 on 2 occasions 6 hours apart, seen in previously normotensive females after 20 weeks. ठीक है, proteinuria में irreversible excretion of 300 milligrams of protein in 24 hours urine या फिर at least 30 milligram per deciliter या फिर 1 plus dipstick in 2 random urine samples at least 4 to 6 hours apart. ठीक है, edema which was included before in the diagnostic criteria has been removed now and excessive weight gain and edema are no longer considered a sign of preeclampsia. Large increase in body weight as well as edema of hands, face or both are common in normal pregnancy. वाटर रिटेंशन बहुत ज़्यादा होता है. किसी किसी पेशेंट में डाइटरी प्रॉब्लम्स नहीं होती हैं. दे टेंड टू गेन ऑलमोस्ट 20-25 kgs. आई टेल यू इवन इन माई प्रेगनेंसी आई गेन 25 kgs in both the pregnancies. I was not pre-eclamptic, I was not PIH, I was just having a good dietary intake because मेरे को कोई nausea वजह नहीं हुआ and I was a very thin patient going from 52 kg to almost 80 kg, तो almost 75 to 80 kg हो गया था. So that was just water retention. ठीक है, फेस और बोथ आर कॉमन इन नॉर्मल प्रेगनेंसी एंड द इंसिडेंस ऑफ प्री-एक्लैम्जिया इज सिमिलर इन पेशेंट्स विद और विदाउट जनरलाइज्ड edema, so that is not in the criteria. So it is A and B. Now indicator of severe pre-eclampsia. What is the indicator of severe pre-eclampsia? A, B, C, D, E. You can choose more than one. Is it IUGR? Is it diastolic BP more than 110? Pulmonary edema, systolic BP more than 160 या फिर oliguria या फिर कॉम्बिनेशंस हैं. क्वेश्चन नंबर 20 लिखो आप लोग, उसके बाद आंसर देना. So that will go according to the criteria which is written in your books. ठीक है, बहुत सारी चीज़ें होती हैं बट इंडिकेटर ऑफ सिवियर प्री-एक्लैम्जिया मांग रहे हैं ये. ठीक है, दे आर आस्किंग इंडिकेटर. What will indicate? Okay, so we have B and D. Can you please write down the question number? So B, D, B, D, E. Pratibha, you're saying B and D. Okay. Surjana, you're saying B, D and E. So this is common among everyone. Confusion है E है कि नहीं है और कोई और criteria है कि नहीं है. Somebody is saying A, B, D, E. Abu, A, B, D and E. Okay. So ये आप लोग क्यों चूज कर रहे हो? Is this the criteria for pre-eclampsia? ओलिगुरिया मीन्स, ओलिगुरिया तो ऐसे भी हो सकता है, वाटर इनटेक कम हो रहा है पेशेंट का. ओलिगुरिया विल बी व्हेन यू आर मॉनिटरिंग ARF. व्हेन यू आर मॉनिटरिंग ARF के पेशेंट को एंड रीनल डिजीज हो रही है, देन यू विल probably think it ओलिगुरिया इज वन ऑफ द क्राइटेरिया. बट उसके पहले, ओलिगुरिया से पहले क्या होगा? इट विल बी द क्रिएटिनिन वैल्यू, है ना. सो किडनी को चेक करने के लिए आप यूरिया, क्रिएटिनिन, यूरिक एसिड देखोगे या सीधे ओलिगुरिया देखोगे? सो दिस इज नॉट द क्राइटेरिया. इट इज B, C एंड D. पल्मोनरी एडिमा, डायस्टोलिक ब्लड प्रेशर एंड सिस्टोलिक ब्लड प्रेशर का क्राइटेरिया. ठीक है, सो दैट इज द आंसर. माइल्ड प्री-एक्लैम्सिया इज BP मोर देन 140/90 बट लेस देन 160/110. सिवियर में मोर देन 160/110. साइंस ऑफ एंड ऑर्गन डैमेज इन माइल्ड आर एब्सेंट, सीवियर में होते हैं. एंड व्हाट आर दीज एंड ऑर्गन डैमेज थिंग्स? प्लेटलेट काउंट लेस देन 1 lakh मीन्स शी इज गोइंग टूवर्ड्स हेल्प. Syndrome, serum creatine more than 1.1 milligrams per deciliter, elevated liver enzymes to more than 2 times their normal value, again help. Evidence of pulmonary edema and new onset visual or cerebral symptoms. Oliguria is not the criteria. Okay. Then all are prognostic indicators of pregnancy induced hypertension except what will not tell you the prognosis: low platelets, serum sodium, elevated liver enzymes and serum uric acid. This is an AIMS question and it's a very clear cut answer, so you don't have to choose more than one. Okay, question number, sorry, I did not put the question number. Did I? I'm so sorry. So this is question number 21. Okay, so write down question number 21 and then write the answer. It's so difficult to write. Okay, this is question number 21. Why is it not letting me write? Okay, Pratibha Yadav, 21D, 21B, Dr. Sanobar. So they are asking what is not a prognostic indicator of pre-eclampsia or PIH. क्या चीज़ हम measure नहीं करते हैं? So that is probably going to give you the hint. So that's question number 21. मैं यहाँ लिखती हूँ, उधर लिखने नहीं दे रहा है, पता नहीं. Probably my hands are a bit sweaty, so the pen tab is not working. Langpoklum, you need to attend my class on Unacademy platform. That's a free class. You have to come on that class. Saturday evening, we have already done one class of 45 minutes. What you can do is you can go on Unacademy Learners app and you just log in by using your mobile number, and then you use my code dr.sonal. That is my code DRSONAL. So you can unlock that class. So you hear that lecture. That was on the Saturday. Saturday was what date? 23rd April ko we did part 1 of this. That was at around 7 p.m. and today again we will be doing part 2, that is eclampsia, and just a recapitulation of what we did. That is again 7 p.m. So, okay, so you'll be able to understand the difference between PIH, severe pre-eclampsia, and eclampsia. Alright, so do we have an answer? Okay, yes, it is right. Abu, 21B, who all answered B is right. We don't measure serum sodium because that is not a prognostic indicator. Electrolytes का as such कोई change नहीं होता है in pregnancy, in PIH. All of the following indicate superimposed pre-eclampsia in a pregnant female of chronic hypertension except. All will indicate superimposed preeclampsia. So there are different types of eclampsias, preeclampsia or PIH or gestational hypertension. There is already a chronic hypertension ongoing and now it has been superimposed with preeclampsia. So all will be an indicator except new onset proteinuria. So that is question number 22. New onset proteinuria, platelet count less than 75,000, increase in systolic BP of by 30 and diastolic by 15, and fresh retinal hypertensive changes. So what is not indicative of superimposed preeclampsia? Question number 22. Question number 22. Nobody knows the answer? You can try. We are not giving you any negative marking. You can try. Okay, 22B. According to you, it is a 22B. Anybody else? So basically, she is a patient of chronic hypertension. इसको already blood pressure high था before pregnancy, right? Now during pregnancy, what happened, which indicates that pre-eclampsia भी हो गया. तो सारे criteria सही हैं except for one. 22D, okay. Okay, so the answer, since you are not answering, is C. Okay, new proteinuria platelet count less than 1 lakh is the criteria, but तो less than 1 lakh में वो less than 75,000 तो आई गया. So this is also right. And fresh retinal hypertensive changes, yes, because now there are fresh changes. They are saying it is fresh, they are saying it is new. Okay, she did not have proteinuria before, she did not have any retinal changes before. Increase in systolic BP by 30 and diastolic by 15 has been removed. This criteria has been removed now. Okay, the incidence of superimposed preeclampsia for women with chronic hypertension is 20 to 30%. It is associated with fetal growth restriction as compared to pure preeclampsia. Superimposed can occur earlier in gestation. We know that, less than 20 weeks. ACOG recommends use of magnesium sulfate for patients with this condition to prevent seizures. Now coming to option C, increase in systolic BP more than 30 and diastolic more than 15 is not a criteria anymore. Okay, so in your DC Dattas it is still written that more than 140/90 or on 2 occasions, measured on 2 occasions 4 to 6 hours apart, or more than 13 systolic and more than 15 in diastolic, but that is not the criteria anymore. Okay, question number 23. Question number 23. PIH is in PIH an impending sign of eclampsia is visual symptoms, weight gain of 2 pounds per week, severe proteinuria of 10 grams and pedal edema. So PGI का question है, you can choose more than one answer. Question number 23. It is not necessary that there will be more than one answer. Okay, question number 23. A, C, D. We have 3 answers here. Combinations are coming. So A, C and D is the main thing that you are answering. Then again A, C, right? Okay, so the answer is actually visual symptoms, because eclampsia में visual symptoms आएंगे. That means there is some problem with the brain. There is some problem in the ischemic changes are happening in the cerebrum. That is why she's having probably going to develop eclampsia and there's flashing of lights in the eye. So it is only visual symptoms, not weight gain, not severe proteinuria, not pedal edema. Weight gain or pedal edema तो हमने पहले ही बता दिया. Severe proteinuria has been removed now because it might be simply an end renal disease, or maybe it is basically indicative of severe preeclampsia rather than eclampsia. It is more of severe preeclampsia because it is giving you an end renal disease. Now somebody just asked, who was that? Shri Jewels, could you please differentiate chronic and preeclampsia? See, in the chronic hypertension, the blood pressure will obviously be, there will be a past history of hypertension which will not be present in preeclampsia or PIH or gestational hypertension. Increase in blood pressure is seen after 20 weeks in the preeclampsia or in the PIH, which are purely because of pregnancy. But in hypertensive chronic hypertension, the blood pressure will be seen rising before 20 weeks. And the superimposed PIH on this chronic hypertension will obviously be less than 20 weeks. More than it will not happen after 20 weeks. Okay. Then there will be no proteinuria as such in chronic hypertension, which has already been removed from the criteria now. BP comes back to normal within 12 weeks of pregnancy. That means within 3 months of pregnancy, the PIH, the PET and eclampsia, everything will subside. Chronic hypertension, the blood pressure does not come back to normal within 12 weeks because she already had a chronic hypertension going on. Okay. So the answer is A here. That is only visual symptoms because they are asking only eclampsia. They are not asking you severe pre-eclampsia. All of the following, now that's question number 24. All of the following may be used in pregnancy associated hypertension except. Now that is a very important question that will be repeated again and again. Which particular drug is contraindicated? It is not that you can't give it, but you should not use it. Okay, so we have captopril. Yes, we have two answers here. You're welcome, Shri Jewels. So it is captopril. Yes. Why captopril? Because it is an ACE inhibitor. And what does ACE inhibitor do? ACE inhibitor causes fetal oliguria, oligohydramnios, because if the renal system of the fetus will not work well, then there will be oligohydramnios. Moreover, it can lead to congenital abnormalities like bony malformations, persistent PDA. Yeah, right. We'll be discussing fetal physiology tomorrow. We'll be having 2 classes on fetal physiology, the circulation, immunity and everything. So attend that class. These are all free classes now, special classes. Respiratory distress syndrome हो सकता है बच्चे में, limb contracture हो सकता है, pulmonary hypoplasia, prolonged neonatal hypotension and neonatal death. Okay, so these are the complications of ACE inhibitors. And last time I told you that furosemide, that is Lasix, that is diuretic, can be used. It is not contraindicated, should not be used, but it can be used in pulmonary edema or left heart failure. So all the conditions which are leading to pulmonary congestion. Okay. Which of the following antihypertensives is not safe in pregnancy? Again the same question, you know the answer. That's question number 24. Question number 24. Sorry, 25. It's 25. Question number 25. Okay, so 24 is over. Everybody has answered B and that was right. And here also we know the answer. So let's quickly do this. 1 and 2 answers, and you just 2 people will answer and I'll go ahead. Okay. Yes, it is 25B, ACE inhibitors and enalapril, right? Question number 26. Which of the following antihypertensive is not given in pregnancy? Same question. So let's just skip it so that we can go aage, because we don't have much time. We will skip this because it is enalapril. Okay, 26 number A. It's 26, not 35, Dr. Sanobar. Probably a typing mistake, 25B. And here it is 26A, that is enalapril, which is an ACE inhibitor. So you will not give this one. Okay. Coming to question number 27. All of the following can be administered in acute hypertension during labor except. Which you will not give? Which drug you will not give? 27. Okay, 27. Sachin, according to you it is C, then comes D, then comes D. Okay, I'll go with D, and that is IV diazoxide. Okay, diazoxide is a kind of drug that is generally used to reduce the CSF pressure, that is the intracranial tension. Okay, although both sodium nitroprusside and diazoxide, they are both not safe. Okay, even this is not very safe, but still as a last resort this can still be given if you cannot control blood pressure, but diazoxide is not given, it is contraindicated. Okay, so diazoxide we will discuss it later. Why is it contraindicated in pregnancy? Question number 28. Drug of choice for severe preeclampsia. Drug of choice for severe preeclampsia. Yes, it is included Langpoclum. It is gestational hypertensive diseases. It is gestational hypertension, PIH, which is almost same, pregnancy induced hypertension, and then the further complications will be PET and then eclampsia. Yes, they are all the different spectrum of the same disease. Okay, so what is the drug of choice for severe preeclampsia? In my Saturday class I think I told you, and today again we are going to just repeat that. So 28A, yes, it is A, it is labetalol. Okay, now labetalol is the medication of choice for the treatment of acute severe hypertension in pregnancy and for maintenance treatment of hypertensive disorders in pregnancy. The reasons for being the first choice is its effectiveness, low incidence of side effects, and availability of oral and parenteral preparation. So we have labetalol oral also and we have IV also. Okay, So this leaves no doubt that antihypertensive of choice is labetalol. Hydralazine, why is it not preferred versus labetalol? It is second line drug because comparative studies of these two antihypertensive agents show equivalent results. Both are good. Labetalol lowered blood pressure more rapidly. Associated tachycardia was minimal. However, hydralazine lowered my mean arterial pressures to safe levels more effectively. So that is, labetalol is more effective in lowering the blood pressure. This is more effective in lowering the mean arterial blood pressure. But hydralazine is not available in oral formulations. Maternal and neonatal outcomes were similar. Hydralazine caused significantly more maternal-caused maternal hypotension and bradycardia. Both the drugs have been associated with reduced frequency of fetal heart rate acceleration. So first line drug is labetalol followed by hydralazine. Okay. Objective of antihypertensive use in seizures, use in seizure preeclampsia to prevent intracranial bleeding and left ventricular failure. So basically the objective of using antihypertensive is we don't want intracranial bleeding so that she doesn't end up with, obviously the main cause of maternal death in eclampsia or preeclampsia is intracranial bleeding. So we don't want that to happen and we don't want the heart to fail, the left ventricular failure. Okay. Then question number 29, again similar question, but the choices are different. So question number 29. Okay. Question number 29, drug of choice for PIH. Okay, the drug of choice for PIH. Question number 29, D, and that is the answer. Yes, that is the answer. That is alpha methyl dopa. The answer should have been actually labetalol, but that is not in the choice. So now for PIH we go for alpha methyl dopa. For IV maintenance of, or not maintenance, for management of severe hypertension, I told you the first line drug is IV labetalol followed by IV hydralazine. But here they are talking about PIH. So the main drug, they have not mentioned hydralazine also. So it is basically alpha methyl dopa, which is a centrally acting alpha receptor drug. And the second will be atenolol is CCB, that is calcium channel blocker. Nitroprusside will be the last resort, and we don't give this, that is enalapril. Okay. Oh my god, that is I'm so sorry, I probably didn't realize that it has gone this way. So we'll just skip that question. It will be very difficult for you, but can you read it? A 27-year-old primary gravida. Question number 30. I didn't get chance to time to reformat it. 27-year-old primary, okay, presents in pregnancy PIH with blood pressure of 150/100 at 32 weeks gestation with no other complications. Okay, 32 weeks, primary, 27-year-old, 150/100 blood pressure. Subsequently, blood pressure is controlled on treatment. If there is no complication, the pregnancy should be terminated when? Question number 30. That's an AIMS question, 2006. Question number 30. She is a young primary gravida with a blood pressure of borderline, it is 150/100, so it is PIH, yes, but it is not severe. It is not going beyond 160/110, and she is preterm. She is only 32 weeks, and everything has been controlled. So what will you do? There are no complications. 40 completed weeks, 37 completed weeks. So somebody is saying A, somebody is saying B. Okay. So 2 more minutes and then we finish. So the answer is 37 completed weeks. Okay. Why 40? Why not 40? Because generally we will not go up to 40 because she will be having this chronic hypertension, and we know that chronic hypertension वजह से बच्चे की growth में problem आती है, placental insufficiency होती है. Such children, they have a lot of cortisol getting secreted within their system, so their lungs are also mature enough. So even after 34 weeks is quite safe. So 37 के बाद wait करने की जरूरत नहीं है. The patient in the question has blood pressure 150/100, mild hypertension, and no other complication. BP is controlled. She is being managed expectantly. In such patients, it should be terminated at 37 weeks. If pregnancy beyond 37 completed weeks, termination is to be considered without delay. Okay. So basically 37 weeks is enough. So let's do one last question and we finish. That is question number 31. Which of the following is or are, you can choose more than one, are criteria for expectant management in preeclampsia? We are not talking about severe preeclampsia, we are just talking about preeclampsia. Okay, so expectant management आप कर सकते हो except when. ऐसा कौन सा क्राइटेरिया है जो कि अगर आ गया, if it has happened, then you will not go for expectant management. A simple way to answer the question. Okay, question number 31. Which of the following are criteria for expectant management in preeclampsia except? That's a confusing question actually. I'm not sure if the question is correctly asked. Because according to us, what we think, expectant management will not be done if she's having visual symptoms. And if she's kind of above 34 weeks, why will you do expectant management? She's already mature. The baby is mature enough. Platelet count is going below 1 lakh, and even this blood pressure more than 140/90, she's basically going towards severe. So I don't think any of these criteria will kind of, or it should be all. Let me read out the answer. They have chosen B, 31B. I don't know why they've chosen this. Expectant management of preeclampsia would be done in mild preeclampsia. Yes, so none of these are mild. Probably just B is mild. And severe preeclampsia before 34 weeks. Okay, so the main aspects of expectant management are hospitalization, daily weight, daily input and output, antihypertensive treatment, beta-methazone 2 doses, laboratory tests to check that there is no HELP syndrome coming in, daily fetal movement count, weekly to as frequently as daily NST, umbilical middle cerebral artery twice every week, amniotic fluid volume, and ultrasound for fetal growth every 2 weeks. Okay, patients with severe preeclampsia need meticulous attention. The criteria to interrupt expectant management and move to delivery, which will be our answer, will be criteria to interrupt will be persistent severe headache or visual changes. So that is it. That is question number D should be the option. Shortness of breath, chest tightness means pulmonary edema, uncontrolled severe hypertension despite treatment, oliguria less than 500. So that is again, we are not going to give expectant management when the urine output is so low, right? Serum creatinine more than 1.5, persistent platelet count less than 1 lakh, suspected abruption, progressive labor, and or ruptured membrane. So I think it should be A, C, D, E. That should be the answer. I don't know what you all are considering. It's a wrong question because they've chosen this. Probably except should not have been there. But if there is except, then these are all the conditions in which you will not go for expectant management. That is it, guys. We will revise the chapter today again in the evening at 7 p.m. 7 p.m. special class we have on eclampsia today, and we will just recapitulate what we read on Saturday. Okay, so all the criteria. All right. So bye bye and take care. Yes, okay, so most of you are answering D, E, C, E, so it's very confusing, right? So that is it, and take care children, and we'll meet you all in the evening, and all the best.